Okay, perfect. Okay, so for those of you who may need to drop off early or those who can't attend, this will be recorded and posted to our YouTube channel later on. So welcome everyone to the State of the Region call. It is Halloween and there's nothing spookier than going over federal and state telehealth legislation pending and enacted. My name is Luke Wortley. I'm the new program director for the Upper Midwest Telehealth Resource Center, but I see some names I recognize in the meeting here. You may have known me from when I was a project coordinator under Becky Sanders and Cam Hilt. If you were expecting Dr. Amna Anwar, she has moved on to another project here at the Indiana Rural Health Association, expanding our efforts in the substance use disorder treatment, prevention, and recovery space. Without further ado, let's go ahead and get going. For those of you who are attending maybe for the first time, whether that's just this particular programming or any UMTRC program, we are the UMTRC, short for the Upper Midwest Telehealth Resource Center, which is a program housed under the Indiana Rural Health Association, based out of Indiana and Terre Haute. Indianapolis and Terre Haute. We are the telehealth resource center that serve the states of Illinois, Indiana, Michigan, and Ohio, and are in a collaborative agreement with the National Consortium of Telehealth Resource Centers as one of the regional telehealth resource centers serving your states, alongside the two national centers, the Telehealth Technology and Assessment Center, as well as the Center for Connected Health Policy. If you have questions about any other regions, you can contact the various regional telehealth resource centers as indicated on this map. And if you have cross-state licensure questions and that sort of thing, just be sure to copy the UMTRC as well on that correspondence so we can get your technical assistance answered or inquiry answered in a timely manner. So our bread and butter, as I just kind of indicated, is technical assistance. We really run the gamut of technical assistance answers, from serving industry professionals to end users to providers at large hospital systems to small independent clinicians. These topics can range from really esoteric billing and coding questions to policy monitoring, legislative updates, to even something as simple as troubleshooting a video conferencing platform. We offer all of this free of charge, as we are a federally funded entity under the Health Resources and Services Administration, which is a division of Health and Human Services, as well as the Office for the Advancement of Telehealth. We provide virtual office hours, which is another opportunity for you to get TA questions asked in real time. We provide webinars, podcasts, and resources. More on that in a little bit. We are also under my new direction trying to initiate a little bit more of a connective tissue initiative in which we will try to sort of be more of a convener for telehealth advocates, creating peer groups for clinicians and providers, as well as potentially academics and aspiring researchers throughout the region, as well as state-specific peer and work groups as well. So today we're going to talk about federal policy and legislative updates in the telehealth realm, a couple administrative updates that have sort of been slow rolling out over the course of 2023. Then I'll get into a state-by-state breakdown and finish with a couple upcoming events, as well as how to get in contact with us after this meeting. So let's just jump right in. In terms of federal policy, there have been a few major developments in 2023. Obviously, the end of the public health emergency went into effect on May 11th, 2023. So we are no longer under a state of declared public health emergency. In addition, we had a new iteration of the Consolidated Appropriations Act of 2023, which allows additional permanent and temporary extensions of telehealth flexibilities. But the important thing, I think, that it should be noted about the Consolidated Appropriations Act of 2023 is that a lot of these telehealth extensions and telehealth flexibilities totally decouple those things from the declaration of the public health emergency. The links for the various summaries, as well as the actual primary source language of the bill, can be found on the link on this slide. The Medicare physician fee schedule for the calendar year 2023 obviously went into effect on January 1st of this year, which gives us a comprehensive list of fees used by Medicare. And there are some other telehealth summaries from the federal government that can be found at that link. The Center for Connected Health Policy, which is part of our national consortium, also monitors the development of the physician fee schedule. It should be noted, I suppose, that the period for public comment for the calendar year 2024 physician fee schedule has passed, and we are hoping to get that published and go into effect on January 1, 2024, at which point we will have a more comprehensive viewpoint for you all. Next, we have the Drug Enforcement Administration and Health and Human Services extending their telehealth flexibilities more specifically. I will comment a little bit more on the DEA, but basically the summary is that due to extensive feedback received during their proposed or after publishing their proposed rule, they received over 38,000 comments, and they have decided that they want to take more time to review all of that feedback, and all of their DEA extensions for flexibilities have been extended through December 31st of 2024 rather than through November 11th of 2023. So we'll get into that here in just a little bit. Just to reiterate, these permanent Medicare changes are not exactly new. They do come as part of the Consolidated Appropriations Act, but federally qualified health centers and rural health clinics can serve as distant site providers for mental health and behavioral health services. That is a permanent change. We anticipate that sticking around for quite some time. There are no longer any geographic restrictions for originating sites for receiving mental and behavioral health services broadly. And in addition, the home is a valid site for Medicare beneficiaries for reimbursement. And finally, one of the other big ones is that audio-only communication is an acceptable form of delivery for mental and behavioral health services across the board, according to Medicare for beneficiaries. Next, some Medicare flexibilities are extended through December 31st of 2024 as part of all of these omnibus bills that were passed earlier this year. And I'm just going to list some of the highlights here. Access to telehealth is valid for Medicare beneficiaries regardless of geography, which is a big change, where beneficiaries do not have to be located in a rural area for reimbursement from the federal government and Medicare and CMS. Receiving services in the home rather than a healthcare facility is another Medicare flexibility that's been extended through the end of next year. Same to reiterate, audio-only communication. And then continued extensions of coverage for any Medicare eligible provider to bill for telehealth services through the end of 2024. Some other considerations that we should probably be aware of that come in the form of various language that has been inserted into all of these different large-scale bills is that HIPAA enforcement from the Office of Civil Rights has resumed as of earlier this year. Basically, a lot of the good faith language is still in effect, but the sort of period where you are exempt from audits has ended. If you want to check out more guidelines regarding HIPAA security and HIPAA compliance, I have posted the link for Health and Human Services guidance here. You can also email the UMTRC directly to ask about some of those things if you have questions. Furthermore, SAMHSA, as well as other divisions of Health and Human Services, have waived in-person examinations and take-home and also have extended their waiver for take-home doses unsupervised for opioid treatment programs, and that has been extended through May of 2024 until a new final rule is published. I do not have any insight as to where that rule is in development and when that will be made available and actually published. So I will be keeping an eye on that. The federal government has issued a lot of support and language for the expansion of several compacts for licensed clinical social workers, counselors, uh, physical therapy, all kinds of different compacts throughout the states. Our 4 states are in various stages of adopting different compacts, and I'll get into that here in a little bit. Every compact also has its own website if you want to see who has introduced a compact and who has adopted one, and where they are in various stages of legislative review. The other thing that I definitely want to stress, not only from looking at various aggregators for resources as we keep here in the National Consortium, but also being in Washington, D.C. last week for the program prioritization meeting for our funding agent, HRSA. They were very careful to address the fact that a lot of broadband infrastructure and access projects are being funded through the federal government, including the FCC and other federal agencies. So if you are not in contact with your Office of Broadband at your state, I'm thinking that many of them are probably looking for cross-sector collaboration to address how those funds are going to be allocated and how to expand and maintain equitable access to care digitally, regardless of geography. So that's something that we definitely are going to be emphasizing here over the next year. This is all relatively repetitive information that went into effect in the middle of this year. Basically, anti-kickback and Stark laws are still in effect, and they went back into effect in May of this year. So basically, if you have a financial arrangement that expired during that time, then you still have to revert back to pre-public health emergency adherence to anti-kickback statutes and Stark laws. There's a couple implications here. Basically, you can read this on your own, or if you have other questions, feel free to email us directly. I'm going to go ahead and skip over this because there's nothing new from our July call. Now, the thing that is new that has been updated since July is that the Drug Enforcement Administration proposed rule, as I alluded to earlier, received 38,369 public comments, and they filed another draft creatively titled the Second Temporary Extension of the COVID-19 Telemedicine Flexibilities for Prescription of Controlled Medications, which is just a revised title from the first one, which just doesn't include the word second. Basically, this just gives the DEA and other federal enforcement agencies the time needed to review those tens of thousands of comments, and all public health emergency flexibilities for prescribing controlled substances via telemedicine will be extended through December 31st of 2024. Which will go into effect on November 11th, which was when the first temporary rule was set to expire. That's all we know now. The final rule has not been published, so we will keep an eye on that and keep you informed as well. As far as the calendar year physician fee schedule from CMS for 2024, it really just includes all of the things that are under the umbrella of the Consolidated Appropriations Act. I talked about some of these things earlier in terms of what Medicare is considering a permanent change and what is being considered a temporary extension through the end of next year. We expect the calendar year physician fee schedule of 2024 to reflect all of those changes. And you will get a comprehensive list published on the CMS website on January 1st. There's another this slide in terms of updates to the process for adding, removing, or changing services on the Medicare telehealth service list has not changed since the last time we presented in July. So I'm going to skip over this briefly. The one thing that I do want to note is that CMS did propose to modify the place of service modifiers that clinicians use to bill for telehealth service and stagger the payment rate for telehealth services provided to beneficiaries at home versus other originating sites. And I know that as part of some of the Appropriations Act, that the acts that the government has proposed for the next fiscal year, to keep the federal government running. In the Appropriations Act for the Department of Labor and the Department of Education, as well as Health and Human Services, some of these staggered rates are going to provide a market increase in reimbursement for telehealth billed through Medicare. So I'll be keeping an eye on that as well, and I'm sure that will affect a lot of next year's legislative sessions throughout our 4 states, as especially during the public health emergency and the immediate aftermath of its ending. There has been a lot of legislation introduced to sort of follow suit in terms of the way Medicare is presenting things in the telehealth space. And we'll get to that here in just a second. Again, everything that the Consolidated Appropriations Act stated in terms of provisions is going to be extended through December 31st, 2024. There are a few clarifications for remote monitoring services. None of this has really changed since March of 2023. So there are plenty of provisions on remote monitoring services at the federal level that mostly are reflected in your state's Medicare or Medicaid provider manuals, and every single private payer kind of does things a little bit differently. So if you have questions on remote patient monitoring, remote therapeutic monitoring, originating and distant sites, that sort of thing, devices, whatever, again, please feel free to contact us directly. Some other proposed policies include raising facility fees, removing certain CPT codes, adding other CPT codes, and essentially extending everything that already was proposed earlier this year through the end of 2024. And we expect to see all of these in the published physician fee schedule for calendar year 2024 in January. In terms of federal pending legislation, I really did try to do a deep dive on what exactly is being proposed right now. And quite frankly, there are hundreds of little implications for telehealth in this bill or this omnibus or that Appropriations Act. But quite frankly, none of this is really that relevant at this current moment if the rest of those Appropriations Acts at the federal level in both chambers are able to pass to actually fund the government's next fiscal year. So we are all kind of in a holding pattern to see whether or not the subcommittees for Health and Human Services and providers and compliance and all of these can actually move forward on some of those bills, because they're not exactly sure what the budget is going to look like. I can't speculate, but I would assume that Congress is quite motivated to get these done, just because there would be a large 1% rescission should they not meet their original proposed deadline that was agreed upon at the end of last year. So we'll keep that monitoring. But if you want to review some of the specific language for these pieces of legislation, I do have a link where our National Center for Connected Health Policy is monitoring all of the status updates for that pending federal legislation. So without further ado, I'm going to get into the states one at a time. And I figured, why not just keep the order the same as we presented back in July. So we're going to start with Michigan. As of earlier this year, Michigan Medicaid reported that 3.2 million Michiganders were enrolled in Medicaid, which is, depending on the metric that you're using in terms of age, almost a third of the state's population, depending on which statistic you use. And for automatic enrollment, renewals will started taking place from June, and will go through May of next year. Monthly renewal notices will be sent 3 months prior to a beneficiary's renewal date, and you can go to that website for guidance on those policies and procedures. It should be noted that as far as Michigan's telehealth rules go, the Michigan Medicaid Provider Manual is kind of your sacred text for for any kind of Medicaid billing, and it was updated on October 1st, 2023. And it is very comprehensive to include all of the latest enacted pieces of legislation that directly affect Michigan Medicaid providers when they're using telehealth. Just to reiterate, though, earlier this year in March, Michigan Medicaid published a bulletin to update its general telemedicine policy guidelines, update prior authorizations, and documentation and consent. You can check out that language there, but it has already been incorporated into the most recent update of the Michigan Medicaid Provider Manual, which also has appropriate links to those pieces of legislation should you want to see the primary source language. Another one that I did want to bring up is the same bulletin that talks specifically about billing. Once again, this has been updated in the Michigan Medicaid Provider Manual, and that link is provided on the previous 2 slides right here. Another one that I wanted to highlight is that if you weren't aware that the very next month in April, Michigan Medicaid's definitions of face-to-face and in-person were clarified and updated due to recent legislation that the General Assembly had published. And this is, again, collated and provided in the Michigan Medicaid Provider Manual. The largest private insurer in Michigan is Blue Cross and Blue Shield of Michigan Mutual Insurance Company. Obviously, if you were going to be billing and coding to a private insurer for telehealth and telemedicine services, you can direct the question directly to the provider for technical assistance, but I will go ahead and give you a little teaser here. The UMTRC has contracted with several consulting agencies and done some back and forth with our own updates and that kind of thing. We will be publishing very comprehensive billing guides for each of our 4 states on the website as soon as we make sure that all of our syntax and everything looks good. And those will be incredibly thorough, 30-40 page documents where that are searchable, that you can find exactly what you're looking for Medicaid, Medicare, private insurance, and all of the managed care entities that govern those payers. Finally, we'll get into a little bit of pending legislation as of October 2023 in Michigan. We have House Bill 5114 that essentially includes the scope of expands the scope of practice for mental and behavioral health providers to include physician's assistants, nurse practitioners, and clinical nurses. This has been electronically reproduced, which is a legislative step in Michigan that they take after the first reading, and that has been referred to committee, and in this case, it'll be the Committee on Health Policy. We also have House Bill 4579, which basically is a parity law that we're trying to get on the books in Michigan. This has also been electronically reproduced after first reading and referred to the Committee on Health Policy. The other one I wanted to highlight is House Bill 4580, which is another parity law. And these 2 bills are being considered in the House Committee on Health Policy, and we'll keep an eye on when they go for a vote and whether or not it gets sent back to a re-referral or makes it to the Senate floor. There are other pieces of pending legislation in Michigan that affect sort of more niche providers, amend some of the administrative code, just to update language, that sort of thing. So these are the ones that are big that I wanted to highlight. But again, there's the link to the Center for Connected Health Policy Monitoring Center right there at the bottom of that slide. So we'll move on to Indiana. As of September of 2023, nearly 2.1 million Indiana residents were enrolled in the Indiana Health Coverage Program, which include all of the managed care entities, fee-for-service, as well as any other Medicaid provider. And this includes anybody basically who is eligible. And IHCP is housed under the Family and Social Services Administration, and you can find that link right there. Automatic enrollment is already ended. So everybody who was enrolled and is not, or was enrolled and has since been unenrolled needs to update their renewal status immediately. As far as Indiana telehealth rules, they have not been updated since September of 2022, but we do have a link to the Health Coverage Program's Telehealth and Virtual Services Manual, which covers most of the all of the Medicaid procedures, billing, and everything that you would possibly need. And if you get hung up on a question, please feel free to contact us. One of the highlights was that was the passage of the Indiana House Bill 1352, which was passed in May, which states that Indiana Medicaid cannot require providers to maintain a physical address within Indiana to be eligible for enrollment as a Medicaid provider, which is quite a big deal and a big step, especially toward expansion and adoption of various licensure compacts in Indiana, making it easier to provide services across state lines. Largest Indiana private insurer is Anthem Blue Cross Blue Shield, and I will reiterate once again, we do have comprehensive billing guides that will be published on the website very soon. As far as enacted legislation, there has not been much activity since May of this year, but we did get House Bill 1352 that I just referenced, along with two Senate bills, Senate Bill 160 and Senate Bill 73, which do actually enact the participation in two compacts, one for occupational therapy and one for professional counseling services. As far as pending legislation, there's not much in terms of large-scale change, but we do have several pieces here, one being Senate Bill 190, which essentially amends current requirements for the collaborative agreement between a physician and a PA. This is going to affect specifically PA's prescription capabilities for telemedicine services, so we'll keep an eye on that. That has been read through once and has been referred to the Committee on Provider Services. We have both Senate Bill 198 and House Bill 1397. Which is yet another provision to try to enact more professional counselor licensure compact participation. It seems to have lots of sponsorship and a lot of bipartisan support, so we could see more expansion and adoption of participation in the counselor licensure compact. I have not seen any further legislation or movement on other compacts. We also have Senate Bill 338, which provides for the licensure of music therapists, and art therapist associates by the Medical Licensing Board of Indiana. This was passed in the Senate and has been given to the House and was read once and has been referred to the House Committee on Public Health. So that's where we are in Indiana. Next, we will talk about Ohio. So more than 3 million people of Ohio are covered by Medicaid. And it's a large, extensive network of providers. Again, in terms of automatic enrollment, normal operations were resumed earlier this year, so Medicaid beneficiaries will have to renew their coverage this year in Ohio. And I will get into one little wrinkle about Ohio here in just a moment. Again, Ohio, just like Indiana, has not updated their telehealth billing guidelines for the Department of Medicaid since July of last year, but all of those billing guidelines are up to date, both through our own research as well as corroborated through the Center for Connected Health Policy. So this is the thing that I was just referencing. We talked about this back in July, but as the Ohio Congress was able to debate and approve budget legislation for the state, Ohio is again proposing rules for Medicaid eligibility that able-bodied Ohioans 55 years and younger would need to work or study for at least 20 hours per week, with certain exceptions as a term for basic enrollment. We will keep an eye on what this language looks like in the future, but this would not actually go into effect until 2025, even if the federal government does issue its approval. Largest private insurer in Ohio is Aetna, and I know that Aetna has made quite a bit of moves here recently, so we will keep an eye on that. And if you have specific questions on anything that they've done, please feel free to reach out. Um, Pretty active legislative session for Ohio this year so far. We have Senate Bill 90 and Senate Bill 28, which both proposed revisions, or not provisions, to enter the social work and physician assistant licensure compact. Both of these bills passed the Senate, were presented to the House, and have been referred to their various House committees. For the social work compact, it's the Committee of Commerce and Labor, and for the physician assistant compact, it is for the Committee on Health Provider Services. We also have a House Bill 136, that authorizes the operation of remote dispensing pharmacies. Basically, this amends a couple sections of the Ohio revised administrative code to authorize the basic operations of remote dispensing pharmacies. This has only been read once and has been referred to committee. There has been no more further movement at this time. And there's another one that's currently been read once and referred to committee, which is Senate Bill 9, which is a revision to medical marijuana, which would allow a physician certified to recommend treatment to make that recommendation using telemedicine. So we will keep an eye on all of those as they move through their various committees and get to the floor for a vote. Finally, we have Illinois. As of July of 2023, nearly 4 million people in Illinois are enrolled in Illinois Medicaid. And for those who don't know, that was a spike of about 1 million enrollees since the onset of the public health emergency. So sizable increase in Illinois in Medicaid enrollment. And of course, like the other 3 states, Medicaid beneficiaries will have to renew their coverage this year, as automatic enrollment ended in June. So as a highlight for some of the enacted legislation, and I'll get to a little bit more here in Illinois, as they've been quite active this legislative session, we have House Bill 4797 that clarifies restrictions around social work when performed via telehealth. I will let you read the bill language for yourself, but essentially it's similar to some of the language that I talked about in Indiana that does not prohibit a person from performing social work via telehealth in the state, even if they do not have an Illinois address, and even applies to people or to the people they provide services for who might not be residents of Illinois. And of course, this provides provisions for students and temporary residents, etc. Illinois' private payer, largest private payer is Anthem Blue Cross Blue Shield. Once again, we have those billing guides being published here in the coming days. Keep an eye out for those. So in terms of enacted legislation, we had Senate Bill 2123, which is the entering of the counseling compact. Senate Bill 2057, which amends the Occupational Therapy Practice Act, basically making language additions and revisions to the administrative code to bring it in line with a post-public health emergency definition. We have Senate Bill 1913, which would apply the requirements around telehealth found in Insurance Act, but is also applicable to state Medicaid. It's just further language clarifying and expanding parity that's already on the books in the state of Illinois. We also have Senate Bill 2059, which specifically defines and adds provisions for veterinary telemedicine. And then finally, we have Senate Bill 1721, which we had talked about back in July as being out of the Senate, but on the House floor. It has since been passed in both chambers and ratified by the governor. Basically, this bill requires patients under 17 to be examined in person before a hearing aid can be prescribed. But for patients 18 and older, they must be evaluated by a hearing instrument professional in person or via telehealth before receiving a prescription for a hearing aid. Furthermore, we have House Bill 2862, which adds a definition to the telemedicine language throughout the Illinois Administrative Code for acupuncture. And we have House Bill 2077, which allows a dentist or hygienist in the military to receive a limited military license, which will impact teledentistry specifically. Next, we also have another telehealth services bill, Senate Bill 1913, which again clarifies and expands some of their definitions for parity for reimbursement in via telemedicine through the state Medicaid program. The only two large pieces of pending legislation that I thought were worth really bringing up, there are dozens more bills on the books in various stages of review, but I have Senate Bill 1585, which amends the Telehealth Act to include athletic trainer in the definition of healthcare provider. So we'll keep an eye on that. That has not made it out of the Senate yet. That has been referred to the Committee on Assignments. And we have House Bill 3721, that would create the Naturopathic Medical Practice Act to provide, among other things, a definition for telehealth for those licenses. And this was already read once and referred to committee. It has since been revised and re-referred to the Rules Committee and has not been moved forward for a vote yet. So that's where we are in Illinois. Do you want to highlight very briefly that the UMTRC does have a webinar coming up in conjunction with the Ohio State Office of Rural Health entitled Closing the Gap, Why People with Disabilities Are and Aren't Using Telehealth, which will be on November 13th from 12 to 1 p.m. Eastern Time. That will be presented by our very own program coordinator, Danielle Rankley. And we will be keeping you posted on any other UMTRC events, and you can go to our website to check that out. Furthermore, for those of you in Illinois, our other program coordinator, Jessica Devine, and myself will be at the Community Behavioral Health Association convention in Chicago. I guess it's in Schaumburg, I believe, December 3rd through 5th. So we will have a booth there. If you happen to be at that event or want to come say hi, please let us know. We're eager to get back out into the community a little bit more now that travel restrictions aren't really as big of a thing, and try to get people to associate our names and faces with telehealth throughout the region. Finally, before I stop to take questions, please connect with all of us on our various social media platforms. If you want to see videos on demand of any of our previously recorded webinars, as well as these State of the Region calls, you can check out our YouTube channel. We also host a monthly podcast called A Virtual View, sometimes updated more frequently than once a month, also hosted by program coordinator Danielle Rankley. And all of any technical assistance questions that you have can be referred to that info@umtrc.org email address, or emailing me directly, lwortley@indianarha.org. So that is all I have for you all for updates at the federal and state level, but I am happy to take specific questions, and even if I can't answer them at this particular moment, I will definitely take them to the research engines and see what I can find for you. Jessica has also posted a link to our evaluation form. These are useful metrics that we must report on to the federal government. So if you have a few minutes, please click on that red cap link posted in the chat, answer a few questions, and provide us your feedback. So I will hang around here for a few minutes to see if anybody has any questions. Thank you, Ling Ling. I hope that that 2024 brings another active legislative session for Illinois in terms of telehealth expansion and advocacy. Also, if you'd rather not use the chat, feel free to unmute yourself and ask a question in real time.